plan is today to talk to you about living with chronic pain in porphyria, along with the other conditions as well, and hopefully my background. And I think I got asked at lunchtime itself, who am I, and what gives me kind of the credibility to actually be here and address you all. First of all, thank you to Sue, Liz, and other members in the British Porphyria Association for giving me an opportunity to talk to you all here. It's good that the conference here is in Reading. It gives me the opportunity. So I'm the lead consultant in pain medicine, and I head the department here at the Royal Berkshire Hospital. I also have the distinct fortune of being part of a kind of national award-winning integrated pain and spinal service. It's a more community pain service for the whole of West Berkshire. So I go out into the community as well, apart from staying in hospital. I look after patients who come into A&E, into inpatient, post-surgery for any other condition, as well as do outpatient clinics and in the community as well. So gives me a flavor to understand the kind of presentations and the problems that chronic pain can have on the quality of life and what patients go through. And in the process of that, do some research with the Reading University as well. At the same time, got some projects started off there, and more importantly, I love to teach. I love to teach about the advances because in the last 15 years, the advances in pain medicine, the knowledge that we have gained by being able to look at the brain a little bit more clearly, the spinal cord and the nervous system, we have so much great knowledge about pain and about how it is processed that it has a profound implication in how we actually practice. How we've been taught as medicine when I did it in medical school has changed, and I hope to convince you of some of that in the next half an hour to 40 minutes and think about it differently. So the plan will be that I shall just kind of briefly touch upon the bigger picture. I think you are in a rare condition there. You have porphyria, which in itself is a rare condition there, but then you also you may be suffering from chronic pain due to other conditions and porphyria itself, and that brings you part of a bigger problem, which is actually an epidemic of sorts. The second part will talk about specifically how much research is being understood as to why does pain occur in porphyria. Very briefly, I think you have had other more illustrious speakers talking to you this morning, so I wouldn't need to repeat too much of the stuff, but the main focus of the talk is going to be on the third part, giving you a bigger picture of the strategies that are there and a kind of approach that I sort of lived by the last few years, the 24/7, what you need to be thinking about and doing about 24/7 in terms of managing your pain. So starting first there, that are the numbers. Our Department of Pain Medicine, we did this for a public open day last year. We kind of put out this infographic about what is the scale of the problem. You're looking at 400 to 600 million pounds per year, depending on which source you want to go, is the money that's being spent on painkillers in the United Kingdom. You're looking at roughly 28% of 28 million, which works out to about 40% of the UK population having had pain that has affected them for at least 3 months or more. That is a significant proportion. When you look at that numbers, this problem of chronic pain far outstrips cardiovascular disease, heart attack, stroke. It's not as sexy as those conditions. You can't die of it. So it doesn't get probably the press that the others are getting, but it by far contributes the biggest morbidity because you have roughly 4 out of 12 of the most distressing conditions ever on the WHO organization are painful conditions. Back pain, neck pain, headache, migraine. All of these are really there. And those are the numbers there. 40% can be prevented from working. So it's a lot of big issues there, and people often contact their GPs often around this condition. And these are the numbers that's there, and you can compare 28.5 versus 10 per million is the prevalence of porphyria. That's the numbers there, but it's a rare condition, but you do have a lot of chronic pain prevalence within porphyria. Without any kind of, if you feel comfortable about it, hands up to those who do suffer from chronic pain of any kind, porphyria or not porphyria related. Okay, so it's a reasonable numbers within here as well, and probably would fit in the 1 in 5 that I'm talking about. And therein comes what we are talking about, why and what we can do to actually reduce pain more effectively. There are proven strategies that are evidence-based that are coming in. Some are available within the NHS, some have not got the level of evidence required to be provided on the NHS. You all come from different parts of the UK, so there will be some difference in what they call postcode lottery, but broadly these are all evidence-based strategies that I'm going to talk about, but these are underpinned by 2 truths and 4 takeaways based on the truth. That's how the 24/7 approach comes along. Okay, so briefly, just to back up just a little bit, these are the basic porphyrias that any one of you probably are suffering from, acute or the cutaneous ones. To be completely honest with you, as an anesthetist, I have looked after porphyria patients. I have looked after them when they come completely stable, but for other surgeries, and therefore I have an idea of what I must avoid and how I must not precipitate a crisis. So the drugs I'm aware of, but I've never had the chance to look after somebody in crisis there. I think the systems here in the UK with King's College and Cardiff are so well developed, and patients like yourself are looked after on that basis that, you know, hospital practice probably any colleagues of mine might have seen, but it is rare, as you all are aware. And pain within porphyria, the present research I looked at isn't that adequate enough. But we are having some understanding of why pain occurs in porphyria, and the reason that occurs is that mainly you're looking at the fact that one of the components of here, which is, there you go, the ALA, which is produced as the first step in the synthesis, is considered to be toxic to the nerves, neurotoxic. So it ends up causing damage to the nerve structures, which is where some of the heme is also changed, and that's why a lot of the acute porphyrias get so much of the neurological complications, the psychological issues there. The visceral abdominal pain is supposed to be another one, because a lot of the liver is basically responsible for the heme synthesis. So when you have a problem occurring in any steps of the pathway, the precursors build up very quickly within the liver there, and it's that problem within the liver that sets off the abdominal pain. This is the combination. There are some case reports in literature which actually talk about the fact that could there be a thing that if the blood flow itself is compromised, the porphyrins can cause a reduction in the blood flow, and actually, like you get a heart attack, could you have a reduction in the blood flow to some parts of the intestine? Is that why the abdominal pain is actually occurring? So there was a couple of case reports that talked about that as a possible reason. And then finally, with cutaneous versions of porphyria, you all are aware that often that part of the synthesis occurs under the skin. When the porphyrins build up in the skin and it comes in reaction to sunlight, that sets off the reaction, and that can start off the pain within the cutaneous porphyria. So you can have pain within the acute settings as well as the cutaneous ones due to porphyrin related damage to the nerves or the skin under there. That is as much as we know. Not enough studies have been done there. But whether you have that, or whether you have chronic pain due to either repeated attacks, or for that matter from some other condition like back pain or neck pain, the next steps start to make a lot of sense, because you may have other treatments that you have within the porphyria for recurrent attacks, but the basic principle that goes through them stays common. And the first truth that you have to take away is all pain is real. Now I know the reason I say that, and to you it will all be very understanding. You'll say, yeah, that is. But you might have also had the experience where some people try to say, nah, that's not happening there. You're just making it up. There's nothing seen on the scan. And some of you may have received that from other people, your family, your doctors, your GPs, or you might have felt that from your own members. And I can tell you here categorically, the research establishes very clearly that all pain is very much real. There are definite changes that occur in the chemistry, in the nerves, in the nervous system, and in the brain every time you perceive and feel pain. And the reason that happens is actually, if I can illustrate there, have you ever seen, this was published actually in the British Medical Journal in 1995. So it's not new hat, this is 20 years old. This was a case report that was published. A builder got into the unfortunate position where he decided to jump and have this nail go through the boot. he was in agony, according to the case report, agony. He was just literally beside himself, just shouting out like anything, and they couldn't handle him. They had to bring him by emergency ambulance. They had to give painkillers while he was in the ambulance. They had to bring him to the emergency department of the hospital there, and he wouldn't let anyone touch. He was just simply holding on to the arm and the leg, with wincing and crying in agony there. They had to give him fentanyl, strong opioids, morphine, nothing was touching there. The midazolam, and they realized, well, they have got to take it up to theatre to have it removed out there. And so they decided one last time, let's give a whole slug of anesthetics out there, give some heavy sedation there, and then gently took away the boot, only to find that the nail had gone between the toes and completely missed it. It was enough to put in the report there, but that is it. And so he had not had 1 inch of contact with the nail into any part of his body. But the sheer visual implication that has there, when I did this and presented another group of public members there, some of them came back completely. That's the kind there, because the visual implication of that does make a difference in how it is perceived. And actually that was there, and that's has changed, so when we are taught about how to define pain, that one was, the first one was a definition which we had. Previously we were taught that pain is whatever the patient says, and then therefore it can be a product of actual or perceived tissue damage. Then it started becoming actually a distressing experience which will have sensory, emotional and cognitive, meaning thinking and social constructs. The most recent definition from this year, early this year, which we now, it's a bit mouthful and it starts to become unintelligible as well, I do understand, but essentially this is the point. If the body and the brain and the nervous system perceives that there is going to be a threat to the existence of that organism, that will manifest as pain. That can be in any form, can be physical, can be different forms as well, but the manifestation will be pain, because pain is ultimately a protective system. It is evolved to protect the organism and to make it survive. It's not the danger signal that we have always been taught about. It is a protection signal, and it will do what it does to ensure that you stay safe. Whether it's required or not, necessary or not, may change with the context, but that's what is evolved as. And that's what we've now understood that is important to there. This one word, if you take it away and repeat there, can you all repeat after me? Nociception and pain are not the same. Okay? And I'll make sure to go there. Nociception is the word you need to understand, because what we all feel is very different. What happens actually? So imagine if you have that particular point there. So that is your peripheral nociceptor. So that can be your porphyrins that are accumulating in the skin in EPP. That can be the porphyrin that's accumulating in the liver when you are having either alcohol or stress or something that's starting the cycle of the start of a crisis. That can be the changes that happen. But when that happens there, that is a nociceptor. That's not your pain point, that's your nociceptor which is receiving a signal. That nociceptor will then send the signal electrically through these fibers, and these fibers will get to the first point over there. Just remember that that cell ganglion that comes along the nerves right to this part, and this is in the spinal cord. That signal that starts from there comes along over here, and it just jumps across here to that part. And then when you have all of this is located in that part. So if I were to cut open the spinal cord at that level of any one of us, that is what our spinal cord will look like. That part there is where that signal is coming from. It comes to this part here, and this is here. From here the signal then starts to travel upwards to the brain. So if you had an acute pain, for example an acute crisis, either when you step out in sunlight, EPP, or for that matter when you are having the start of a crisis there, what actually happens? And this is not just for the crisis in porphyria, this can happen with any, your acute back pain, your IBS, your pelvic pain, your angina, your headache, your migraine, does not matter. The underlying principle is the same. When you have the signal occurring there at that level, the nociceptor gets included, the nociceptive signal comes down there. I've called it pain impulse, but actually I should be saying nociceptive impulse. Comes down there to the neuron there. The signal releases some chemicals. Then after that it gets stimulated. That signal then gets amplified and it goes up to the brain. And the brain then decides, you know what, where did I feel this before? Is this the same thing that happened to me last year when I was walking in the bush? Is this the same thing that happened to me when I was picking up the toy at the time and it went? Did it happen before? Has it happened for the first time? Where am I? If you're alone at home at 8:30 and you've not ordered pizza and you hear a doorbell ring, that's going to be a different response to when you've ordered pizza and you hear a doorbell ring. Okay, there's a difference there, but that changes the context. And that realizes there that the signal is different. So the brain is automatically going to say, have I had this pain before? Where is the signal? What happened the last time? Is it anything similar to what I've had? All of that is calculated in microseconds there, and it decides what's the quality, what must be done about it, and then it will say, well, you know what? I think it's all right. It's a pain. I'm going to respond to it, and I will sort it out. And meanwhile, because it started in the periphery, the healing will occur. That will settle down. Your crisis, the porphyrins will be washed away, the enzymes will come into place, it will go down, and the pain should go away. But the brain will remember, because it will know when it happened, how it happened, in what context it happened, what were you doing at that time when it happened, and it will remember. It's safely archived because it's got to protect you the next time. A child will touch a hot plate the first time, it will not do so the next time. It can learn that fast and that early. We are not going to repeat an unpleasant thing again. But that's what we'll remember. That will be docketed away. So what happens when it starts to become chronic? What's the change? The change occurs, everything stays the same. Nothing alters there. But now you have the same stimulation, you have the same signal, but now what happens in some cases, and in most people, you may have a slightly extra damage. So recurrent attacks of porphyria, recurrent going out there, will start to release newer chemicals. Those newer chemicals will set up more changes in the local area, and it can make it all very inflamed. And then after that, the signal will make it all very hyperexcitable. If you have had back pain or any other condition where you felt, or a knee pain or a hip pain, and you felt after a few weeks it seems to spread out, now it's not just the knee at that point, it seems to be a little wider, that would be the reason you'll have. You'll have a bit of hyperexcitability of the nociceptors, not pain, but nociceptors. Those signals will then go, it will amplify the whole system. This is the shortcut that is included by the brain to ensure that the next time it occurs, it's got to be incredibly quick. Think of you driving. When you're learning driving for the first time, you're driving, you're looking at mirror signal, maneuver, what's my left leg, what's my right leg, what's my hand, where am I, what am I doing? And now you might be in a situation where you have no idea how you got from A to B while listening to music, and you're there. Your hands, but everything has been done. That's a circuit that's been set up, remembered, sorted, so that it goes at the background at a very comfortable level. That's what it has to do. This is how it actually happens. The biology and the chemicals, this is how it makes it happen, how the body ensures everything is sensitized and amplified in order to be ready for the next time you feel that. So the brain starts to change a little bit. It starts to alter itself in order to make sure that the systems are robust and is ready to protect you every time. And that system was what we call as wind up, because it occurs in the spinal cord. And that was all called peripheral sensitization, because it starts off when you've had maybe a crisis, or maybe you had a back attack or a knee pain or a slight arthritic change that has set it off there. What happens next is, in some people, you have a change here in the spinal cord where everything gets amplified at that level. The brain decides, you know what, I just don't think this is going to happen. I don't really care anymore whether anything's happening there or not. I'm just going to make sure the system is so ready to be primed to protect. I don't really care whether any more damage occurs there. This is not really required of the brain, but then it can get into that habit. And what happens with that is that there are usually a system from the brain where it tries to dampen. Everything the brain controls is, if the signals are coming up, it has a downward signal as well, trying to dampen it. Those systems get slightly turned off because the brain has another system which it starts to activate, which actually excites the whole thing. It kind of sets up a full feedback process saying that the next time the pain signal comes, I'm just going to make sure I wind it up some more. I don't really care whether anything is happening in the back or something's accumulating in the liver or a skin is going to go out. I'm just going to make sure that this EPP person doesn't just go out. I don't think going out is important there because the least sunlight can just set it up because I'll just make this all right. Because why take the risk of actually having harm? Keep protecting. Is it really required in the social world that we live in? Probably not. But we are human beings, our organism as a species, we need to protect to survive and to live on. That's all the brain is interested in. And it will do that because it will change the balance, the yin and yang. It will alter that. It will do anything to ensure there. And there it sets up another new pathway, direct shortcut all of these things, directly into the limbic system. And the limbic system is responsible for your emotions, for your anger, for your mood, for your fear, for tension. Therefore, it will wind up such a way that if you're going to feel angry, it will just say wind up the mood. Get the pain up. If you're feeling stressed, get the pain up. I don't care really what it is. Anything that comes as stress, get the pain up. That's it. And it will do that. It will set up a feedback loop. You see in all of this, nothing's changed in the peripheral nociceptor. All of this is occurring within your spinal cord to the brain. This is a system that's entirely set up independent of what you have to do, occurring in the background to ensure you're protected. And that means that all of this will change the brain accordingly and alter it. And because of that, that's called neuroplasticity. I'll come back to that term. That's one of the takeaways. And all of this is occurring in the spinal cord, and you need to have this changes occurring, and that's called central sensitization. That is what is responsible mainly for the chronic pain that most of you have, most of my patients and community have. This is driven to a certain extent by the changes that occur that are independent of what happens in there. So when you get an attack of pain due to any condition, due to knee pain or attack of migraine, it's not that you're having a new set of arthritic changes happening in the knee or the hip or the back. It may very well be this as well, and that needs to be remembered because that should give you the power and the confidence to say, it's not my knee, it could very well be this, and what can I do to change that? Because that makes a big difference in how you manage your pain. With this point here, nerve pain is slightly different. Some of the acute patients can get that kind of crisis when I said the ALA can be neurotoxic there. What happens is that you will have some damage to the nerve itself, to the nociceptor, and that can bring about some changes which can occur in all these conditions, whether you have pressure in the porphyria, it would be the toxic. But you can have change due to trauma. You can be a road traffic accident. You can be metabolic. You may have diabetes, alcoholism, blood pressure problems. You can have an infection that can be really bad, or you can just have pressure, be just intense pressure that you've been sitting on. Some of the coccyx pains can come across like that, or neurological. All of them change there, and you'll have multiple changes. I won't go into this so much of biology there, but it all changes. A lot of changes in the nervous system that ensures that the brain does what it does to protect you and to ensure you live. That's all it's interested in. And in a way, all of these are changes that occur in the nervous system without anything happen to your knee or your back or your disc or your bone or your muscle. All of these can happen independently. That's what the research of the last 10 years proves us. So therefore, coming to the first takeaway, the pain is the body's alarm system. That's what you need to remember there. It's not a danger signal. When you get your next attack of pain, it doesn't tell you what's going wrong. It could just be a sign that the alarm system is there to protect you. Sometimes the alarm system, as in most people, you can have an oversensitive alarm system. It might just get more sensitive, and you have even, a leaf goes past, it can start blaring away. It doesn't have to have, I have an alarm system at the back of my garden there. Fox goes, the lights come on. But the problem is sometimes even the leaves go past, the alarm comes on, and I get worried thinking, what the hell is the light coming on for at 11:30 in the night? But there you go. And if you see it long enough, I will probably calm down after a little bit. But my wife saw it about 2 days ago, and she said, there's something in the back of the garden, go check what's happening. The lights have come on. And that is a problem. An oversensitive alarm system is an issue. It's not perfect, but it is what it is. It protects us. Because that's the issue there. An alarm system can sometimes give too much importance there and needs to do. The other term, pain, is bioplastic, meaning that it can be reversed. It will get reinforced, but you can also bring it back once you understand that. Because this symptom of neuroplasticity that I told you about is very important. All the changes that I told you in the brain that happens when it gets the stimulus there can be brought down back. It takes time, but you can bring it down, and it can be reversed by a variety of strategies to put in there. Another thing to remember with all these changes that occur, nerves, that fire together, wire together. Remember this, actually repeat it with me. Come on, nerves that fire together, wire together. And that's very important there for you to remember, because this is a neural network. So for example, this is called the neurotags. What has been a very good research work in the last 10 years is, let's say you have the first episode of pain. The signal comes along, one set of nerves takes the signal, takes it to the brain, converts it, comes back, all of those changes occur, gets reinforced. The next time the pain comes along, the nerves have all got sensitized, the tag works quickly, the whole network is extremely fast and primed. Your broadband speeds have gone up to fiber level. You don't have patchy broadband, you've got full on, immediate answer, quick on. And then after that, the brain is not going to really have, let's say it uses up 100 nerve cells to set up this network. Some of these nerve cells can function other places as well. So what it does is, I'll just take a few of the networks that help in that anxiety thing, and I'll just incorporate it here. So every time you get a little anxious, your pain will just flare up because two networks have joined together and the overlap is there. And if they fire adequately enough times, they will wire. So after some times, you don't have to have a pain receptor or a nociceptor to give a signal. If you have one anxiety pathway going on, it can set off the pain pathway. The networks are so robust now that one set of nerves is fired together, it will start to wire together. And that's the same. That's what we noticed that with the anxiety system, with the depression system, with the anger system, with the pain system as well. All of these systems, if you fire together adequately enough, you will wire together. And this has an implication because, therefore, if you work on any of these, you can influence the whole network. You don't have to just focus only on the pain and getting rid of only on the pain. If you focus on all the other things as well, you can have a definite influence on the pain. That amount of takeaway is very important to take on, because that gives us many options rather than just painkillers which have problems and side effects as well. And the important part, we've come across with fantastic research. The last takeaway before we go on is pain is felt everywhere. We used to think, and I was taught in the 90s in my medical school, and so have all your GPs and all your doctors and every surgeon and top-notch consultant and professor that you see. We were taught that there is a system, and this is 400 years of medical world medicine that goes through. We've been taught that if you start with a pain, you will feel it somewhere, it will go to the back of the brain, one particular part, and as long as you can take away that part which starts off the pain will stop. That's why surgery has come along. That's why everybody looks at a peripheral target. Give a steroid injection, give a nerve block, give a knee injection, give a knee replacement, give a hip replacement, do back surgery, do anything. Do IBS, look for the colonoscopy, look for a gastroscopy, look for the period of pain, because we were all taught that if you do that there, it will be done. Because again, we were told that once the pain goes to one part of the brain, it's just a very specific structure in the brain where there is a pain center. And once you go to the pain center, it comes back from the pain center. The pain center doesn't talk with any other center. There's an anxiety center, there's a depression center, and never the twain shall meet. That was the plan. But actually, when they started doing the MRI studies, that's when it started to really go wrong, because when you started to look at where the pain is processed in the brain, and you started doing these MRI things, look at all these names there, that's almost the entire part of the brain. And actually, there are about 7 to 8 centers in the brain. They all talk to each other. The neural networks span across every part, from the front to the back to the side. There is an overlap. It happens, and the change is there. And therefore, now, if you look at it, look at some parts of the brain. You've got that part there, prefrontal area. That part there is responsible for your creativity, is responsible for how empathetic that you feel towards your family, is responsible for how you think about things, your intuition, your decision making, but it also looks after pain. Your other part of the brain is called the somatosensory. It's responsible for pressure, position, vibration, touch, but it's also responsible for pain. Your other part of the brain, your emotional self-control, your ability to problem solve, it's also responsible for pain. So if you have pain, your problem solving capacity could get affected, because these are all networks that are all connected to each other. Your posterior parietal lobe is where your sensory, your visual, all your hearing, your thinking, all of that. Remember the builder that I told you about? This is where the network is individualized. he's looking at something, he's looking at a boot there, that's enough, because pain is perceived there as well, is modified and changed there. That is your biggest. If ever you remember everything, everything revolves around the amygdala. Have you heard of, those of you know Ronnie O'Sullivan, the snooker player? So he had a psychiatrist who kind of looked after his mood. He kept going crazy every time. And Steve Peters was the psychiatrist looking after that, and he talked about the chimp paradox. You have a monkey brain, the part there. That is your monkey part of the brain. That's your reptilian brain. That's your primitive amygdala, which is where your pain, your breathing, your emotion, your heart rate, your animal senses are all there. When somebody does something silly, whether you're at home, whether your family, with your children or anything, that's all due to there. But that's where pain, your emotional extremes, your pleasure, everything comes off that structure. And it can overlap and it can confuse. And you have more areas. The hippocampus stores the pain memories, but it's also responsible for storing all your memories and converting in the evening. It converts your, when you sleep, it converts those short-term memories to a long-term memory. If you have excessive pain, why you can't remember, why does it affect your memory, how you think, is because it affects there. Understanding the emotional attachment to deciphering what's pleasant and unpleasant. You can see that all these areas help out with pain as well, and it's important that you understand because it gives you opportunities to tackle all of these. And that brings us to the strategies that are there. I have about 7 strategies, but in all they encompass everything. And if you're able to put all of these, the main important thing is put them together where required. Sometimes one is enough, but just depending on one alone, which is what we end up often doing, is actually a flawed strategy. It doesn't work for anyone, doesn't work for anybody, not even medical doctors. And the first strategy, yes, medications are a good one, whether it's porphyria, whether it's the use of the acute attacks, whether it's use of opioids, morphine-like drugs. You've got something for the recurrent attacks that you've talked about there, but they are just one aspect. When it comes to pain drugs, luckily almost all the painkillers that are available in the UK market are safe for most parts of porphyria, whether it's cutaneous or acute porphyrias. But what's important to remember is that they will work, but this is the data, this is the research. Only 30% of the drugs work 30% of the time in 30% of the people. So if you have had conditions wherein you feel, oh no, this drug didn't work, or it gave me side effect, it's actually known, we know it. We do know that it doesn't work in everyone. But the unfortunate is we've got variety, and you might be one of the people who don't get along well with morphine, but oxycodone works well. Who doesn't like codeine, but tramadol does the trick. Who doesn't like patches, but actually a simple drug does the trick. Ibuprofen may not work, but naproxen could do the trick. But it's a bit of trial and error because that is the data right now. And all drugs have problems. Paracetamol probably, but even paracetamol in your condition, too many hepatic changes is an issue. The doses get low. But that's the important thing to keep in mind, that what you have to do is trial, error, patience, work with your GP, work with your specialist, and be happy to try a few ones because you might get the right drug, but it's only 1 out of 7. 1 out of 7 strategies. Because how do they work? If I take you back to logic, I find this helps with a lot of my patients when I try to explain the drugs that they do. If you think about that, when I showed you the peripheral nociceptor, showed you the nerve, showed you this part here in the spinal cord where the jump is occurring, and then the brain there, and you remember these things, the signal that goes up, the dampening system that comes down, yeah? So you've got few things. You've got a nociceptor over there, you've got a signal part here, you've got a jumpy bit out here called the synapse, and then you've got the brain above there, you've got a dampening system, okay? Based on that, the dampening system from above, that's where your amitriptyline acts, your nortriptyline acts. So it's a dampening system. It acts on one part, okay? And that's why duloxetine. Because they act on the nervous system, you're going to get some of the side effects. You can't get an amitriptyline that doesn't cause a bit of drowsiness because that's how it acts. Nortriptyline, duloxetine, whatever, that they have got to do it that way. Then you've got all those changes in the nerves that come along. That's where people who have been on valproate or lidocaine patches, local anesthetics, that acts over there, those who have trigeminal neuralgia. The jumpy bit, the synapse that I spoke about, that's where the gabapentin and the pregabalin act upon there. So for me as a pain specialist, some GPs say, you can't combine. I actually teach them, we have to take the advantage of the fact that if only 30% of the drugs work 30% of the time, You give a small dose of gabapentin that sorts the jumpy bit. You give a small dose of the amitriptyline that dampens the signals there. You then use 2 drugs at low doses to calm it down. Now, if as a patient you're going to feel, I don't want to be on 7 different drugs or 8 different tablets and I'm already on 3 different heart attack tablets I can't have, it's a difficult situation because we have to chance. If I increase and I give you only a gabapentin at a high dose, it's going to cause more side effects, and I'm tackling only one part of the pathway. I can tackle it on multiple levels. Why won't I choose a smaller option rather than go after one alone? Ketamine, methadone are just acting everywhere. They act on multiple receptors everywhere. And then there are a few other peripheral, on the skin receptors, wherein if you've got excessive sensitivity, you can have capsaicin patches, chili patches and all this stuff. There are newer things that are coming out, each of them looking at the periphery. But that's where medications are, because there's still a potential. The newer drugs coming in the pipeline. 10 years later, I might be giving you another talk about a few more chemicals. But this is where we are with drugs. They all have problems. They all act only 30% of the time. But they are good options to try. They are not the only option though. And next we come to interventions, a second strategy. Again, you have specific interventions for porphyria, which those of you who have EPP or AIP know. I won't go into that. But the difficult thing for other interventions for painful conditions, remember this, it's got to be the right patient at the right time and the right intervention. And what do I mean by that? This will shock a lot of orthopedic colleagues of mine and physios and chiropractors there, but I don't know if you can see well, but essentially this talks about neck pain, shoulder problems, hip problems, ankle problems, knee issues. And these are all studies that have been done on patients who do not have ankle pain, shoulder pain, neck pain, hip pain or knee pain. And what comes out is when you do an MRI or an X-ray on these people which have these problems, they all show signs of arthritis, of labral tears, of knee tears or anything there. So actually asymptomatic people have changes in their joints and bones all the time, 60 to 80% of the population. If I did an MRI scan of all of you, and if you didn't have any back pain at all, I'd be putting my professional line and be telling you 80% of you will have changes in your back, which in another phase and time will be told, oh yeah, that disc is a problem, but it isn't. These are all changes that occur with age. They do not have to be the pain generator. They could be nociception, but they are not necessarily the pain. Because if you did the study, they actually took it. If you took people without back pain and put them there, 40% of 20-year-olds are already going to have changes in their spine which are classified as degenerative. So you don't have to have a back pain to do this. This is what is there. 96% of all, anybody who's lived about 70 years of age, 90% of them are going to have changes which will be called as disc bulges or disc changes or facet joint changes. So having other painful conditions do not mean the pain is necessarily coming from the structure. I'm not saying it's not, but you have to swallow it with a big grain of salt when a surgeon or an orthopod or a GP or anybody else tells you that's arthritis from the knee there, because that's not the reason alone for the pain. It may be a nociceptive signal, but doesn't have to be the pain. So I don't deny, go for it, go for an injection if you fancy, but actually think very clearly about the surgery or for any other parts there if you're not convinced, if the situation is not clear. Ask that question of yourself and of that. How many of you saw the program from 2 days ago? There you go, a few of you there. The placebo effect is something that's known, and I encourage all of you to have a read. It's surprising, doesn't apply again in everyone, but it is food for thought to just think about that, about how it can do, because they've actually done that. Patients who had fake surgery as well, they recover. In that program, they talk about somebody with shoulder surgery there. We've now got the data to actually say this was a surgery that was done for back. People with 80-year-olds who have a fracture of the back there, there came this brilliant idea that, let's put a little bit of cement in their bones, make it strong, and the pain will go away. And it worked out. There was a huge industry going along. Everything was going hunky-dory. And then about 10 years ago, they did this study where they said, let's balance it out. Let's do 20 people put cement in. Another 20 people, we'll do the whole trapping. We'll take them through surgery. We'll anesthetize them. We'll put them on the table there. We'll make a needle cut and not do anything. Just come out. And actually, those people got better as well. The pain got better. And that became a problem because now actually vertebroplasty is not commissioned, not funded anymore on the NHS. Because they're saying if you can just get away without doing, that means the surgery isn't working at all. And that's where they stop. The same is with knee arthritis. Simple keyhole looking into the knee has now been decommissioned throughout the UK because of the same study that has been done. They did the same study where they did 100 people get a knee arthroscopy, a cleanup and a washout, and another 100 people were actually taken through, they were looked in, they did the tiny cuts on the outside, but they didn't do anything else. Came back out, patients were woken up, went back there, they recovered the same way. Good percentage recovered. So actually they were decided not to fund it. What's problem is the language. The language that surgeons use, sometimes unfortunately GPs use, a lot of our colleagues use, your parents or your family members use, is unhelpful language. We are trying to change that because words like crumbling spine, twisted pelvis, completely out of alignment, wheelchair bound, you've got shattered disc, oh my God, I've not seen anything like that when I looked inside you. These are all really riddled with arthritis. These are really unhelpful terms which are completely wrong and flawed because they do not explain the pain. They may talk about what the nociceptive things look like, but they are not the reason for pain because that's a totally different construct. Throughout my back, slip disc. If you can avoid that in your conversation, that will be a great start. If your chiropractors tell you that that really is difficult to have, their working probably works on a different way than what they have, but that's the way people have been taught there. And we do have to change in how we think. And if anything you would want to do, please look at these two. TED Talk by Lorimer Moseley called Why Things Hurt. 40 minutes of pure genius from this pain research. I would recommend you to look at, goes into greater detail. The other one is this book called Explain Pain. Gives you a fantastic set of ideas on how you can look after yourself with a lot of the things there. Good reading for the public, very nicely explained. Makes it easier for you. And that's important because when you understand how you can look after yourself with pain, you can use it as part of a strategy, not just depend on the next surgery or the next tablet to sort it out, because you have a whole lot of power in your hands. The next part, you may scoff at this and I'm say that I'm getting into touchy-feely stuff, but we've now got the research to back this up and actually say that you are what you eat, especially in the last 70 years with how we've been eating processed foods. We really are not doing any good to ourselves and to the friendly bacteria that we coexist with. And again, that's very important to understand. We've now discovered in the last 10 years that actually our bacteria in our body, in our intestine, are probably a great immune organ in themselves. The intestine along with the bacteria is called the microbiome. That is a separate organ itself, that is a separate immune system itself. 70% of your serotonin that you get, 50% of the dopamine that you have in your body comes from the intestine with the help of these bacteria. These are powerful immune system stuff, and we are disturbing them with our processed foods, with the kind of junk food and the sugar-rich foods that we have here. So the research is very strong and very good to actually say we need to look at what we eat, because you've got these pro-inflammatory foods, and if you can look at the Porphyria diet, you guys are aware, and it's all similar. What you must do within the Porphyria diet is very important. Don'ts also overlap, and you come along here. How many of you have seen this episode from last year, Doctor in the House? Have you heard of that? This is a GP who got this brilliant idea. BBC did this idea wherein if you had only 8 minutes as GP, but what if you flipped it around? What if we had a GP come and kind of stay with you for 6 weeks at a time? And so a GP from North Manchester did this series with BBC into its 3rd season. But the 2nd season, if you just look at that episode 4, if you get a look, it talks about fibromyalgia, but it talks about other chronic pains as well. And he focuses on actually how much you can change with lifestyle, how much you can make a difference with diet, with exercise, and you can improve considerably in how you look after your pain and that helps, and that will help with the Porphyria aspects as well. But the important thing, this is across the board. If you can cut out this even for 6 weeks in your life, I can guarantee you that you will notice a reasonable improvement in the ability to manage your pain. Okay, cut out all of this stuff there and you will notice that change that happens there. And these are the other foods that are making a big deal into there. The Mediterranean diet overall is the big gun that's coming through. The next step, a strategy, sleep. Absolutely important. I told you, if I remember, the hippocampus, the region of the brain that converts your memories into long term, all of those structures in there require that amount of sleep for optimal function. We are considering now 6 to 8 hours is where we are looking at, and you can do that. If you go to the American Sleep Society, that's the Google website there, they have something called sleep hygiene. A lot of you may be already doing it, a lot of it is common sense, but if you stick with it, try out those principles for 4 to 6 weeks, see if you can incorporate that in your life. Again, another 20-30% improvement in the pain that you feel, in the way that you can manage your pain there. I've got a couple of slides, they put it as do's and don'ts. I've written this for a group of fibromyalgia patients that I look after because that's one of my specialist interests there, but that's what works. It's too small, don't worry if the presentation will come from Sue, but if you go to the website, I've got this from the American Sleep Society website itself. And the next, and not by any chance less important, but exercise, vitally important. I know for some of the EPP and for some of the cutaneous porphyrias that can be tough, that can be difficult given the condition there, but there are opportunities, a home gym, anything that you can do. The physical exercise is vitally important because that conditioning, that amount of change, that blood flow to the nervous system and to the muscles is vitally important. If you let it decondition, no amount of surgery or tablets will ever fix that. That is a certain road to not good work at all. And it's very important to go past that, because you've got these issues there. You've got a lot of changes and benefits that come along. The last, but certainly not the least, and this is where all your strategies come along. A lot of these have been decommissioned and not provided because the quality of evidence is supposedly not great. But these are the ones that have the powerful influence, because anything, acupuncture, yoga, Pilates, all of these what we call complementary therapies have a huge deal to play on, because whether you do osteopathic, chiropractic, or any of these swimming, hydrotherapy, they all work on this aspect here. I've already established to you, nociception is just one part of the problem. If you can change affect and context, you will influence pain. And affect and context are everything that is changed by meditation, by mindfulness, by yoga, by chiropractic, by osteopathic. That is where your biggest target comes, is going after these. So I would encourage you to really look at those and incorporating those, not to look upon them as the only thing, not to look upon any of these, but use the entire 7 strategies, and that's what will make a difference there. Because that integrated option is what manages. I love this thing and I use it a lot in my patients and in my practice really. It is a victor there. If you treat the disease, you might win, you might lose. But I guarantee you, if you treat the person, you will be a victor every time. I think that's what a lot of doctors should come around to. A lot of us are starting to do. But I think if you treat your body and your pain the same way, if you just treat one porphyria, one back pain, you might win sometimes, you might lose on other days. I guarantee you, if you put some of the strategies that's there, you will win every time. Thank you.